Okay, next we have cholelithiasis, gallstones. Okay, so one particular, let me go back real quick. One particular thing about gallstones is one specific sign that they always tell you to look for is what is it, Kenny? What do they tell you to look for?
Murphy.
What is it? Murphy's, yeah.
Murphy. Yeah.
And that posterior shadow, right?
Uh-huh.
So gallstones are usually mobile, right? Because they're stones. They're usually mobile structures within the gallbladder that cast a prominent shadow, right? And I explain how that does that in the fundamental stuff.
Mm-hmm.
And then in the neck, gallstones towards the neck of the gallbladder, they're less likely to be mobile. And the gallstones towards the neck, they're more likely to get impacted or stuck. Now there's two things that could be mistaken for gallstones. One is sludge. You've seen sludge, right, Kenny? If not, I'm gonna show it to you. And then the other thing is gallbladder polyps.
Uh-huh.
Sludge, sludge, it could be mobile, but sludge doesn't cause that posterior acoustic shadow because it's not dense like a gallbladder. And polyps, it doesn't cause a posterior acoustic shadow, and neither mobile or nor cause a posterior acoustic shadow. Make sense?
Yeah.
Ooh, okay. I'm gonna show you something now. Boom, boom, boom. Oh, I gotta do a new. You with me, Kenny?
Yeah. You're doing something. What are you doing, man?
I'm just gonna show you an
Can you
ultrasound
show
real
me?
quick.
Sludge?
No, an ultrasound. Can you see this?
I can't see anything. Well, I see no. I see nothing.
Nothing.
What do you well describe? I see a black screen with something that says recording. Oh, yeah, I see your desktop.
How about now?
Yeah, I see something.
Okay. All right. So in this one, okay. So this one, which way is the fundus, Kenny?
Which way is the fundus?
Yeah.
Just tell me which
So
plane
which
I'm in. I don't know what plane I'm in.
tell me which plane you're in, bro. Do you see the
Tell me what plane
gallbladder in
I'm in.
profile?
I think I do.
All right. It's all long and profile, right?
Mm-hmm.
Ooh, hold on. Okay.
I think I see the
Right.
exclamation point you're talking about.
Yo, yes. So what plane is this?
This is that.
Tell me,
That's a
man.
good
I'll wait
question,
for you.
man. Longitudinal plane.
Yeah.
Imagine
Longitudinal
so.
plane. I'll take that. Along the longer length, right? And we see the longer length of the gallbladder. Longitudinal, right?
Mm-hmm.
You with me?
Yep.
Okay. And you see the exclamation point, right?
Mm-hmm.
And then do you see how the gall within the gallbladder is anechoic, but there's certain regions that are hyperechoic,
Within it?
like right here. You see that?
Yeah, kind of.
It's
Mm-hmm.
hypoechoic, right? What do you think that is?
Bile.
It's not
Sludge.
normal bile or
Sludge.
sludge, right?
I don't know. I never heard of sludge before until 5 minutes
It's
ago, to be honest.
yeah, it's just concentrated bile, bro. Sludge could also cause impaction or
Okay.
obstruction,
Yeah.
but it's just really concentrated bile. It's
Mm-hmm.
not normal, but it doesn't
Okay.
cause a posterior acoustic shadow. Do you see a posterior acoustic shadow?
Nah.
Not really, right? But you see something hypoechoic. It's supposed to be anechoic, so that's sludge. And what did I say about the exclamation point in that last video? Tell me.
Mm.
In case people didn't watch that last one, you just tell them. I
The
gave you control,
portal
by the way.
vein,
I
man.
gave
It's a
you control
portal
over the
vein.
mouse.
Is it a portal vein? I hope it's a
Portal vein,
portal vein.
right? And what
Okay.
causes this area right here to be
Oh, that's the
hypercool?
mid liver flexure. Middle?
Main liver fissure, right?
Main liver fissure.
Yeah, it's the fissure that divides the liver into right and left lobe. And which side of that fissure is the gallbladder in?
Well, if I'm talking about my own gallbladder, it's on the right
Yeah,
of a
yeah.
patient on the seat. If I'm looking at a patient face to face, it's going to be on the patient from my left. That makes sense? Yeah.
Yeah, exactly. I got you.
The
And then
patient's right.
what does the transducer marker indicate? What is this side?
That's superior.
Uh-huh. And what is this towards the narrow?
Anterior.
What? The narrow portion of the beam. Like where am I putting this if I'm getting a longitudinal scan? Where's the transducer placed?
Interior, right?
Anterior. Oh, I thought you said inferior. Okay, good. Good job. All right, that's all I wanted to show you.
All right.
Hopefully I could just... Am I back to the slides now?
Mm-hmm.
Cool.
Yeah.
Okay. So I think that's what I just showed you. Okay. Next. Oh, so that was this is a gallstone, and I showed you sludge. So those are the only two things. Look for the posterior acoustic shadow,
Mm-hmm.
and then
I don't think we never talked about sludge, man. I don't think we're gonna have to look for
I've seen it
sludge.
somewhere before. Anyways,
Really?
where's the
Okay.
fundus here?
Where's the
And where's the
fundus?
neck?
I don't know, man.
Well, fundus is the... What did I say is the most anterior and inferior portion of the gallbladder? Remember
Border
the
part?
sunflower, the sad sunflower?
Yeah, I remember that.
Yeah, what is the
Wait,
most anterior inferior portion of the gallbladder?
there's a head, fundus, and a neck, right?
Yeah, it's the fundus, right? So
What's the
where's
fundus?
anterior here?
What's the head then?
Huh?
That doesn't matter. Okay.
Where's
What?
where's the fundus here?
Where's the fundus?
Yeah.
I don't know, man. Is that
Okay,
where your
okay.
arrow is?
Get your landmarks right. Where's the anterior? Can
Interior's
you
the
click on
top.
the screen so you can take control? Click it.
Give me
Kenny.
control, man.
Oh shit, my bad.
Yelling at me and shit.
Alright, go.
Okay,
Click it.
okay, okay.
Where's the
Yeah.
fundus?
You see my mouse?
Yes.
Okay, I'm gonna say fundus is here. This is fundus.
Is that anterior?
This is anterior.
And what's the most anterior part of the gallbladder?
No way. So this is the fundus.
Yes. Where's the neck then?
I don't know, somewhere here.
Yeah, exactly. So that's where if there's a stone here, it's more likely to cause impaction. Cool?
Yeah.
Moving on. And the middle is the body. We already watched the video. Okay, we're done with gallstones. Next, acute cholecystitis. So these are the... Okay, so the acute cholecystitis is usually caused by gallstone. Key findings are things that cause gallstones, or what am I saying? Key findings of acute cholecystitis. Okay, presence of gallstones, sonographic Murphy sign. What's a Murphy sign, Kenny? Real quick.
It's pain on
Yeah,
the
it's just
upper
tender
right.
when you press with the transducer against the gallbladder. Gallbladder wall thickening and pericholecystic fluid, which is fluid around the gallbladder. Now, these findings could present alone or in various combinations with abnormal lab values. Simple enough. And they don't all have to be there, basically, is what I'm saying. Okay. So, Kenny, what view is this?
Axial.
Yeah, because in the axial view, the gallbladder basically looks like what?
Circle.
A circle, right?
Right.
Okay. And then you remember when I showed you the normal gallbladder, the wall is very thin, right?
Mm-hmm.
In this area, this whole white rim is the wall, so this is pretty swollen.
Mm-hmm.
Okay, cool. And then here you have, so this is the gallbladder, the anechoic region. This is the wall, and then you see this little thin line of anechoic signal, right?
Mm-hmm.
That's not supposed to be there. So anechoic signal is usually fluid. So this is pericholecystic fluid. Now you have to be careful and follow that fluid. If that fluid connects with a whole mass of fluid, that's ascites. If this fluid is basically just around the gallbladder wall, but if this fluid were to connect with a whole bunch of other fluid in the peritoneum, that would be... This is intestine. Don't worry about this, and this is probably an artifact, and this doesn't really connect with this. But this thin line of anechoic signal is fluid around the gallbladder.
Right.
But there's a case in the RRE where this you have ascites. Another thing I want to say is, like, if you have fluid around a structure, you see how this is the gallbladder, right? You can see the outline of it, a nice circle. But when there's fluid surrounding something, it messes up the normal delineation of the anatomy. So it'll look like there's a dip here. It looks curved and jagged. The normal anatomy of the any organ is not like that. But if it looks like that, if the borders are looking all jagged and not smooth, it's most likely, especially in ultrasound, it's because there's fluid around it and it's making it look like that. And you'll
Mm-hmm.
see that there's an RE case with ascites. The liver looks like that.
Mm-hmm.
Cool. Okay, I'm gonna watch one more. Well, what is that? 19.7, right?
You made this PowerPoint?
Yeah, bro. Try to make it all comprehensive and understanding. All right, look at this. Oh, this is a nice one, bro. What do you see, Kenny? First of all, what plane is this?
I don't know, man.
Yes, you do. Do you see the gallbladder?
Longitudinal.
There's a lot of abnormal things going on here.
Yeah. What's a beating like a heart?
That's because they're moving the transducer. Let me double
Uh,
check something actually really quick. Actually, we skip something. First, okay, first, I'm just going to read this case presentation. Can you see the screen?
I still see the ultrasound.
Ultrasound?
Mm-hmm.
Oh, no. How about now?
Nope.
You don't see anything?
No. Oh, yeah, I do.
Okay. You see case presentation?
Yeah.
Okay, so an obese 56-year-old woman presents to the emergency department with severe right upper quadrant pain. She has had similar pains intermittently over the past several months and has known gallstones. She reports having had an ERCP 2 months prior for similar symptoms. ERCP is both a therapeutic and a diagnostic tool. They insert some kind of catheter that has imaging capabilities, and once you see the gallstone, they insert it in the bile duct. If you see gallstones, you can also remove it using the same method. So it's both treatment and diagnostic. So basically, she had gallstone removed, most likely. And she's afebrile with mild elevation of her liver function test and a leukocytosis of 16,000. Your primary differential diagnosis, acute cholecystitis and cholangitis. And this is the ultrasound from her. So just first, Kenny, what view? Like I said before, with gallbladder, they usually just use those two, axial, or they use that longitudinal plane. So what is this? I know it's not
Longitudinal.
normal, but just tell me like what it looks like most, resembles most like
Longitudinal.
longitudinal, right? Where's the liver? Right here, right?
Mm-hmm.
And this is superior transducer marker, anterior, posterior, and then this is inferior. And then
Right.
so what's up?
Mm-hmm.
Okay.
Yeah.
So I'm just gonna play this, okay? I'm gonna pause it now and then. Boom. Okay. Right here, right? Something's there.
Yeah.
Okay. What is this?
Shadow.
Shadow, right? So there's a stone there, and then this is the anechoic region is obviously the gallbladder, but then you see this stone around this hypoechoic region. So what this is sludge. So there's sludge and there's a gallstone amidst the sludge. Okay,
Mm.
make sense?
Yeah.
Okay, I'm gonna pause it again. Boom. Hold on. What is this?
Stone.
Stone. Another, because there's two stones, and this is towards the neck, also in the middle of sludge. And there's one last cool thing. Pay attention to the border of the ultrasound, okay? Or of the gallbladder, okay? Look at this. You see that right here?
Mm-hmm.
What is that? Look at the rest of the wall, but then you see that? It's like a
Yeah.
valve opening up, right?
Mm-hmm.
It's perforated. This gallbladder
Perforate?
is perforated because this is
Shit.
the wall, right? You see how it opens
Yeah.
up like a valve?
Yeah.
Watch
Yeah.
this.
Yeah. I see it.
Yeah, so that gallbladder is perforated. And then there's sludge inside the gallbladder. There's hyper
What's
echoic signal around it, and there's fluid. Like you see all this anechoic signal. You see that? So
what's
this is the
that?
wall. Oh shoot. Okay, you see this wall, right? Obviously, where it's perforated, where it breaks. You see that, right? Bam. You see that?
Yeah. What's that anechoic thing to the left?
You mean on to the anterior or to the
To the superior. Superior.
Superior of it, right? That's
What's
fluid.
what's that anechoic? No. Superior.
This,
Yeah.
this,
Hmm.
this is within the liver. This is probably some kind of vein,
Hmm.
hepatic
Hmm.
vein or something.
Yeah.
But what do you think this is? This anechoic region on top of the wall?
It's fluid.
Fluid, pericholecystic fluid, right? Okay. So that's what's going on here. It's perforated gallbladder with sludge and gallstones and pericholecystic fluid. It's a bad day. All right. So for this one, that's all I wanted to say. Gallstone impacted in the neck. Boom. This is the neck, as I made you say earlier. This is the fundus and pericholecystic fluid and debris, which is basically sludge. Okay. Bam. Same again. Okay. And then she had this is just case resolution. She had a positive Murphy sign. Longitudinal view revealed the large gallstone in the neck, gallbladder wall thickening surrounding edema. A second gallstone is in the body of the gallbladder. Then there is a possible focal perforation of the ventral gallbladder, which is the same thing as anterior, with some pericholecystic fluid. And then, so what did they do? They, because it's perforated, obviously she's going to need surgery, but they're not going to do surgery right away because it's perforated and she has leukocytosis. So they gave her antibiotics, pain medication after she improved from the acute illness. After no possibility of it, after she, because you can't do surgery if she's in the middle of an infection. So later on, they did a surgery pretty much. And then it says one last thing, which is that large gallstones may have a dramatic appearance, but small gallstones are more likely to become impacted and cause symptoms. Gallbladder
Oh.
neck should be thoroughly evaluated for impacted stones in patients presenting with upper quadrant pain. And that's pretty much all I have.
Hmm.
All right.
Woo-hoo.
So, how did we do, Kenny?
Pretty good, man.
Cool,
I'm
cool,
ready.
cool. I did my best. All right. So, like for the rest of the class, if you guys have questions, please reach out. If I don't know it, I'm gonna find the answer. If I know it, I'm gonna explain it to you the best I can. That's the best guarantee I can give. And Kenny, thank you for doing this with me. You definitely made this better. Um,
Glad to help.
yes, sir. I appreciate it. And that's all. So peace. Kenny, peace.
Later. Whoa.